Hi, everyone. Thank you so much for joining. Costly, Ineffective OCD Care has met its match. I'm Marissa Plesha. I'm a reporter for MedCity News. Very excited to be here to moderate this very exciting and important panel. We have a lot to get to and not a lot of time, so I'm just going to go ahead and pass it along to my panelists for some quick introductions.
Good afternoon, everybody. Really excited to be here for this panel, and thanks for joining us. I'm Doug Nemesek. I am a psychiatrist and the Chief Medical Officer with Evernorth Behavioral Health, and really responsible for making sure that all of our customers, everyone we are helping, has access to high-quality, evidence-based care and for obsessive-compulsive disorder, which we'll be talking about today.
Good afternoon. My name is Stephen Smith, and I'm the co-founder and CEO of NOCD. I'm really grateful for everyone here who joined us this afternoon. So my background, I actually have obsessive-compulsive disorder. So I started the company NOCD after my own journey where I was misdiagnosed about 6 different times after having an initial onset of OCD symptoms. And eventually, because of the misdiagnosis, I hit rock bottom where I had to leave school. I was in college at the time. I was playing football at a small school down in Texas. I had a great social life and a great family support and friends. But at that, I ended up getting so severe that I had to basically put all that to the side for a moment. I became housebound, and then eventually, after learning what I was going through had a name, I tried to find evidence-based treatment, and I ran into a series of challenges with that. Treatment wasn't effective, affordable, and convenient at the time. And eventually, though, I was able to jump through a few hoops. So I saw a specialist who does evidence-based treatment for OCD called exposure and response prevention therapy, and that ended up changing my life, where I was able to eventually get through treatment. I went back to school. I finished up my degree at a small school down in Southern California called Pomona College. I finished up playing football, and at that point, I realized that this was an operational issue. At the end of the day, it wasn't a clinical issue. We just didn't do a good enough job identifying folks who had OCD and then giving them the right care at the right time at the right place. And so that was the catalyst for starting NOCD, and 10 years later, here we are today. So really grateful to be here. Thank you.
Good afternoon, everyone. My name's Jana Dost. I am the head of network strategy for Evernorth Behavioral Health, and very much focused on provider partnership, and why I'm here today to represent Evernorth and just talk about how getting patients, our members, to the right provider at the right time is critical to our strategy at Evernorth.
Hello, I'm Frank Webster. Very honored to be here. I'm Chief Medical Officer of Behavioral Health for Healthcare Service Corporation, which is the short way of saying Blue Cross Blue Shield of Illinois, Texas, New Mexico, Oklahoma, and Montana. Which I won't say that again. But thank you very much. My background is emergency and community psychiatry. Also worked at Kaiser Permanente when they were in Texas, which was many years ago. So I have that integrated service delivery. Also teach health informatics, so very much a data nerd. And like many people in clinical care, I had a person that I knew that was really good at treating OCD, so I would send people to one person. And so it very much a condition that requires people to know what they're doing. And so that's when we met in OCD, other than the contracting issues of the many, many years that it's taken for them and the patients that have exhibited. They're a wonderful group and just super excited, and we've also just done some really cool data analysis on outcomes with them. So very excited about this discussion.
Great, thank you all. And we will be taking questions, so I believe there's a QR code up there if you would like to submit any questions. We'll try to save some time for that. But Stephen, starting with you, you talked a bit about your personal struggles with OCD. Maybe you could just set the stage for the audience and talk about the challenges with the way that OCD care has been traditionally offered and what you've done with NOCD that makes it different.
Sure. Yeah, great question. So to start, I'd like to first highlight what OCD is actually like for people here in this room who may not fully know yet. OCD is a condition which differently. OCD is a term in the English language which almost everyone recognizes and almost everyone also misunderstands. It's very rare you have that where people casually use a term which people recognize, but then they don't really know what they're talking about. And it's a condition that is very misrepresented simply because of the fact that you often don't see what people are suffering from. You see the actions that they do to eventually try to make their suffering go away. And the way it starts is people have these intrusive, recurring fears thoughts, images, or urges, they oftentimes violate the person's core values and character, and they oftentimes can be about taboo subjects such as violent fears, sexual fears, religious fears, relationship-based existential, so very different from that pop culture definition. And then to make those fears go away, people do specific actions. Sometimes you can see those actions, they're visible. Sometimes, though, you can't. Sometimes they're only happening in somebody's head. And the problem is with OCD, when people are suffering, they're often embarrassed about their core symptoms. They don't disclose what they're going through to even their family. And what that does is over time, that leads to a lot of people being misdiagnosed. And when they get misdiagnosed, then they end up going to different providers who sometimes even mistreat them. And so when you think about what's broken today for OCD care, it starts with oftentimes people will go to treatment that isn't necessarily effective or evidence-based for them. In fact, sometimes talk therapy can be even harmful because people will be taught to do the specific behaviors that unfortunately reinforce their fears and cause them to suffer more. So like first challenge is effectiveness. The second challenge is if you can finally get identified effectively and sent to evidence-based treatment, you oftentimes run into affordability barriers. So the evidence-based treatment for OCD, exposure response prevention, historically would cost about $300 to $400 out of pocket per session, and people would have to go to sessions for upwards of 20 times in a given year, sometimes 30 times. And so if you think about that, it's a cash pay business that's out of pocket from a patient stance. It just isn't affordable for most people, even if you could finally understand what you needed to get. And then finally, there's an issue with convenience. If you could get to evidence-based treatment, if you could afford it, most of the time, you are actually suffering between sessions on your own. So you'd see your therapist once a week, and between sessions, when your OCD is at its worst, you'd be forced to manage on your own. And so at NOCD, what we really try to do is solve those three issues. So we've made effective treatment widespread throughout the United States, so people, no matter what state you live in, no matter if you're in an urban setting or rural setting, you can actually get access to effective care. Two, we've made that treatment affordable. We've partnered with leading payers all across the country. We have about 154 million commercial lives under contract today, about 92% of commercial lives overall, and we have aspirations to begin serving folks in Medicaid and Medicare segments. So we've made the treatment more affordable. There's still work to be done, but that's an area of focus for us. And third, we've made the treatment more convenient. So people can access their NOCD therapist. They can do live face-to-face sessions with them, but they can also get support between sessions from peer communities, self-help tools. They can asynchronously message their clinician or a member advocate, someone like them who's actually gone through treatment before. They can utilize different peer feeds. They can attend live support groups. So we've given them a series of ancillary services between sessions that allow them to stay healthy even when their clinician isn't available or in inopportune times, right? Because again, you may be walking down the grocery store aisle and boom, all of a sudden you're having an OCD fear. What do you do in that moment? How do you manage? Right, and that's what people with this condition unfortunately have to go through. But if you can, honestly perfect the treatment, become your own therapist, you can get better. Yeah.
Very well said. Thank you for sharing that, Stephen. So, Doug, Frank, and Jana, bringing it back to you, is there anything you would like to add on some of the challenges that you experience from the payer side when it comes to your members with OCD, and what led you to working with NOCD?
So I think Stephen hit on what I think is the biggest barrier, and that is the misdiagnosis or the trouble getting to the right diagnosis. Because ultimately we know if we can get the right diagnosis and get people into the right care, they've got the best chance of getting actually better and recovering from their illness. But as Stephen said, too often we end up with the wrong diagnosis, which leads to, care that's not effective, or the symptoms get worse and the patient ends up going to more intensive care, or with obsessive-compulsive disorder, they end up in long-term residential treatment and things like that, that if we could have gotten them into the right care in the first place on an outpatient basis, maybe we could have prevented a lot of the suffering as well as a lot of the treatment that wasn't helpful. The other piece that I think is really important is the ability to really know who are the specialists to provide that care. So as a payer, when we put our network together and we've got hundreds of thousands of therapists in our payer network across the country, traditionally we just ask them, what conditions do you treat and are you comfortable treating? And people check depression, anxiety, obsessive-compulsive disorder, panic disorder, they go down the list, and they say they treat it, but we don't know at what level of competence, what level they're truly an expert, or they just have seen one patient in the last 10 years with that, right? And so the ability to make sure we're sending, as a payer, people to providers who are actually expert in that care and we know are going to provide evidence-based treatment, really important.
Yeah, I will just pile on to what Dr. Nemasek is saying in regards to, we hear from clients that it is the right care at the right time. So at Evernorth, as we're thinking about provider match and getting people to the right specialist, we look and have trained our clinical care coordinators. So a team from NOCD has come and presented an OCD 101 course to those coordinators. So they are taught, what are those indicators? What are we hearing when someone's calling that's going to say, wait a minute, I think what you're calling in about may be better suited to a specialty group like NOCD. And this has really been significantly, I'll say, a game changer for us as we think about directing people to the right care at the right time. And we hear that feedback from our clients and our customers, meaning our patients' members. So it's been very successful in helping us get people to the right care. And OCD is such a specialty niche and requires those providers who are trained specifically in that modality that we are seeing exceptional results.
And for us, the part of the struggle is just having our network team understand what obsessive-compulsive disorder is, what the model of treatment is, that therapy is not the same for obsessive-compulsive disorder as it is for depression or anxiety. And we were very blessed because we've had about 400 or so people in treatment with an OCD in our system. And I've got a good team of data analysts. And we just modeled out. We looked at 6 months before somebody went into treatment with an OCD. We looked at what happened after they started and what happened 6 months after they ended treatment. And for the 6 months before, it was a flat line of about $1,500 a month of medical and behavioral health spend. It was literally a straight line. It wasn't like it was ramping up. It was flat, so I'm guessing it was a longer straight line than 6 months. It immediately dropped about $400 a month the first month they engaged with an OCD. And when you think about the model of the illness and the behaviors, you have a lot of the worries are not uncommonly medically related. So you see a high spend on scanning, on kind of repeated lab values, lots of ER and primary care and urgent care visits. The medical spend is what drops immediately. And we see that persistence through the entire course of treatment, and subsequently when somebody is kind of had their last session with an OCD, at least for a given year, we also see that continue. It makes a huge difference, and what's fascinating is it's almost an immediate difference. Within that first 30 days, things change drastically. And there are good programs available, like Rogers Memorial in the Midwest. They have a residential, partial, and an intensive outpatient program. UCLA in the West Coast has got partial and intensive outpatient programs. The McLean Hospital has an OCD program. But prior to an OCD, outside of academic medical centers or just a person who took an interest in it, there wasn't a systematic option available for people. So this is a game changer for this population that is suffering with this condition. Yeah.
Just to add to that point real quick, there's 1 in 40 people suffer with OCD, and one of the challenges that the Atlantic highlighted in 2015 was that despite the prevalence, I think there was only a couple thousand therapists that were trained in the evidence-based treatment for people with OCD. So if you think about that disparity, that's ultimately what we've tried to really solve. We've tried to make sure that we could first and foremost identify folks and then get them to the right care at the right time at the right place, and then ensure that they can stay healthy once they've gotten better. And so it's been a great amount of learning over the last decade in trying to solve that problem. And so, I think you all said it really well.
And I would say that 1 of our 400 went to residential at Rogers, which I'm assuming was probably because they were too severe. If we had picked 400 people we knew were having an OCD diagnosis, probably 20 of those would have been in those higher levels of care programs. Again, it's not that they're bad, But this is better. It keeps people at home and gets them engaged. And again, the response is very quick when in that ERP treatment.
So going off of that, you mentioned medical spend. Can you talk a bit about what makes traditional OCD care so expensive? That's for any of you.
Well, I could get in trouble, but I usually do. My boss is not in this meeting. Okay, that's good. So, yeah, it is a lot of worries about, do I have a brain tumor? Do I have cancer, right? There are intrusive thoughts. And unfortunately, once they enter in once, I may have a thought, do I have cancer, but I won't have that thought repeatedly and not be able to get rid of that. And then the mythology, unfortunately, that happens when somebody with OCD is they think that getting the doctor to assess and running the scans will stop the thinking. The problem isn't that I'm worried about I have cancer. The problem is I have a circular thought pattern. So the solutions that are sought until they get into ERP actually cannot make it better. They actually just become self-perpetuating and reinforcing. And unfortunately, if you're engaged in like a psychotherapy that's more focused on how do you feel about this, that actually does not help people with repetitive circular thinking improve. In anything, you could argue it might make them worse in some ways. So the healthcare system for this particular group actually perpetuates and probably exacerbates their problem until they get into the ERP.
Yeah, I would agree with that, and it gets back to what we were talking about at the beginning, which is making sure we have the right diagnosis to start care, right? And one of the things that has been a real benefit of working with NOCD at Evernorth has been the fact that on several occasions we'll have other clinicians reach out or families reach out to us because they don't know what's going on with their loved one and they're not getting better and care is not helping, and even when we don't know for sure that this is OCD and get them over to NOCD for care, but it might be. Let's get that assessment. We've referred people over to NOCD, get that assessment done there by the specialist. If it's OCD, they get them into appropriate evidence-based care. If it's not, then we can also say, okay, we've done that highly evidence-based assessment. It's not a diagnosis of obsessive-compulsive disorder now. Let's go down the other path and see what else we can do to make sure that person does get where they want to be. And that's been really helpful for as we try to sort people out and get them connected to the care that's going to be most effective for them going forward and not run up unnecessary costs, unnecessary treatment, and all the complications that go with that.
Yeah, just to add on, with that, what your team has done an excellent job is to redirect the care. You're not holding on to them just to keep holding on to Dr. Nemesek's point, but we see that, right? And the clients also see that.
Well, we appreciate that. The key that we've realized too, and it's just thanks to a lot of the great feedback and advice that we've gotten as we've built, as we work together over the years, is that we have to, at the front end, give a comprehensive assessment because without that, people not only can get ineffective care, but they can get harmful care. And that's the major challenge today, from what we've seen, where people will end up spiraling in the system for decades. And it's not just they're spiraling in the system, like they're losing out on their life. And so it's having a chance to get that diagnosis up front has been the key starting place for our team. And the good news is, too, there are many other great specialists that are starting to emerge in the behavioral health community at a significant scale. And so when you have other in-network providers that you can refer to for other issues, it makes the ecosystem just flow that much better.
Yeah, absolutely. And I want to shift gears for a moment. One thing that we're reporting on a lot at MedCity is there are just so many digital health companies out there. There are so many digital mental health companies. It's really important to find a company that works and has proven that it works. So, Stephen, maybe starting with you, how are you measuring success with your patients?
We look very closely at our clinical outcomes using our internal measurement-based care platform. We call it NODO. And we, first of all, run that assessment that we described. And in that assessment, we assess, first of all, does someone have symptoms of OCD, both patient and clinician reported outcomes, or I'm sorry, of questions. Second, we run a comprehensive biopsychosocial. We run DOS-21 to understand their depression, anxiety, and stress symptoms. We'll look at a quality of life scale. And so we do a comprehensive assessment up front. And if they meet the diagnostic criteria, then they'll engage in our evidence-based protocol. And we have peer-reviewed research for adults as well as upcoming children in our treatment. And then we'll measure at the midpoint and the end point of treatment in our protocol if somebody is improving. And depending on their scores, we make clinical decisions as a team. And once someone gets better, then we end up helping them stay healthy because OCD is chronic, right? So you can help someone manage, but you can't cure them. So the idea is help somebody go from a high acuity level down to a low acuity level in as short of a time frame as possible, and then keep them at that low acuity level long term. And so that's how we measure outcomes in the clinical front. We're just now starting to also measure economic outcomes alongside some of our payer partners, and you've heard some of those outcomes here today. But that's an important focus for us because we want to ensure that we can ultimately, at the end of the day, help people have a great quality of life, where they're living their life, they're not having to worry about their OCD as much, they're seeing out of the healthcare system as much as possible because they're spending their time living their life and enjoying their life.
And I just want to comment on the quality of life issue. The fact that the spin changes and it's all medical. Think about this. That's important, but what that means is that you're not spending time sitting in an MRI scanner. You're not going to the emergency room. You're not going to. It's like you're not doing. Those are not fun things for anyone. It is a huge quality of life. It shows up in the cost, but what that actually means is that person is actually having much more freedom in their life than they had prior to that.
Yeah, so going off of that, Doug, Jana, and Frank, can you talk a bit more about the outcomes and results that you've seen among your members as a result of working with NOCD?
Yeah, absolutely. So we've been partnering with NOCD for about 4 years probably now, something like that. And so we've had about 4,000 or a little over 4,000 patients now from Evernorth that have gone through treatment with NOCD. Within that, we see, some people would say, well, gosh, it's a virtual platform. Maybe it's just the really mild cases, not the other ones. But what we're seeing from the scores is, as Stephen was talking about, they do that assessment. They understand the level of severity. About 15% or so are low severity and mild. We got about 80% that come in as look like moderate severity of OCD symptoms, and then about 5% are the really severe cases still getting treated through NOCD. And across the board, what we're seeing from an outcome perspective on our Evernorth patients is that they have about a 35% decrease in their OCD symptomatology, right? Pretty significant decrease in symptoms and really getting better, that level of functioning getting a lot better. You mentioned they track the depression and anxiety symptoms as well. Those are down 40+% as well, both of those. And so really seeing across the board that people are getting clinical improvement, symptom reduction. And the other thing we look at then is how long does it take to get better, right? Are they in treatment for 4 years before they get better? But actually, on average, it's about 16 to 18 sessions with NOCD, right? So really comprehensive, appropriate evidence-based treatment, showing those clinical improvements over an appropriate period of time, over a few months. And so driving really good results. And then as well as what Frank had mentioned before from a cost-saving perspective, we've also done some of that analysis to show that, after they get into treatment with NOCD compared to getting treated just out in the wild by somebody else in our network, we're seeing significant, over $250 per member per month who's in care with NOCD, improvements in cost compared to not. So really good results. And that is why we then choose to partner with NOCD, because they are able to share the data, they're doing the outcomes, they're providing evidence-based treatment, and really showing that we are helping individuals who need that care.
Jana, anything to add?
Doug did fantastic, and it definitely is the cost of care savings. And again, back to my point of the right care at the right time. And this really comes down to particularly those with comorbidities, and getting the right NOCD care helps in lowering those costs overall. And to your point of reducing time and being worked up for something that really is not correct in the diagnosis.
Frank, I know you already mentioned some results, but are any more that you would like to share?
I mean, not really. I think, you know, my daughter has actually had treatment with an OCD. I recommended it to her because I knew John and Stephen and like, okay, these guys are for real. And her comment was, this is the first time in my life I've ever actually talked to somebody who had a clue as to what I'm going through and could give me concrete help. And you know, this is the kind of thing that we have heard over and over again from folks that have been engaged with an OCD. And you know, it's not 30% of the population. It's a much narrower slice. But the problem is that people can look really good superficially. You know, they can hide their symptoms. They can be productive at work, but they're miserable. And being able to change that is actually really huge. I just can't speak enough to how that can change somebody's quality of life.
Yeah, absolutely. And going off of that, there seems to be a bit of a debate of working with a condition-specific solution that really specializes in that specific condition versus going to a broader platform that may support a broader group of people. So, you know, maybe Stephen, starting with you, can you talk a bit about why it's important when it comes to OCD to go to a solution that is really specializing in that specific condition?
Sure. Well, it's a great question. So people with OCD, when they get access to exposure and response prevention therapy, they can get better. Right? It's one of the most treatable, stigmatized, high-cost behavioral health populations, and the reality is, without treatment, ultimately the condition gets worse and worse. So you really want to make sure you get to the right treatment with OCD. And the good news is it is treatable. You just need specialized treatment. And I think that's what oftentimes people don't realize when they think about behavioral. For some issues, you can go to a therapist and you can do talk therapy and you can actually be beneficial. Others, you need specialty treatment. So it's a really heterogeneous population, right? The people who have mental health challenges. And I think, you know, for certain conditions, it's different. But for OCD, you really need that specialty intervention. And we happen to be the group that provides evidence-based ERP at scale for children, adolescents, and adults.
Doug, anything to add?
You know, I would just say I spend a lot of time talking to clients, employers, brokers, other purchasers of care and insurance. And they're always talking about we need more access to behavioral health. That's the big issue everybody raises. We need more access. And usually the comment that we make back in that conversation is, it's not just access, right? It's the right access. It's access to the right provider to get treatment for the right diagnosis. And that's what really people are interested in. And we get lost sometimes talking about, oh, it's just about access, get a bigger network, get more providers, just make sure that somebody see this person. That's not the answer for people with obsessive-compulsive disorder. We want people who specialize in that care, can make sure that the diagnosis is correct, and then can consistently deliver evidence-based care. And that's what's going to really drive the clinical improvements and improve the population.
Jana, Frank, anything to add?
I mean, in some ways, I'd put it in a similar bucket as eating disorders. You know, what you need, and I know Wendy's sitting right there. What you need rapid access to people who are really trained and focused on this. Both of those conditions can have pretty bad outcomes. And having providers that are really skilled and understand how to manage those conditions is really critical. So there is the broad access. It's a huge issue. And I'm in another panel tomorrow talking about that, but anyway, we won't talk about it. But but broad access is important, but access to those specific things that have a specialized service is just as critical, in some ways more important sometimes.
Yeah, and I'll add on, as we focus on matching a patient to the right provider, not only is that optimal for the patient, but it's for the provider. So when we send a potential patient to a provider and they may have a couple sessions and they're like, wait, why was this person directed to me? It's a frustration for the provider as well. And so not only are we focused on the right experience for the patient, it's also the right experience for the provider. And so their time is valuable. So we want to ensure that as we, our clinical advocates, guide to the right providers, it's the right time spent in the right direction, right? We don't want someone going and it's provider's time, it's using up their calendar space for someone else that would be more appropriate. And then we ultimately hear back from both the provider and the patient saying, wait, this was not matched right. So at Evernorth, we have spent a significant amount of time to ensure that we're getting it right the first time. And I think that's been resonated multiple times. And I know all payers are trying to do that, but it's definitely a focus.
Stephen, was there something you were going to add?
Yeah, and just to go off of your point, I think that starts with proper identification, right? And the problem with very stigmatized conditions in behavioral health is that they're oftentimes misidentified up front because people don't want to talk about their core symptoms. Like, for instance, a mother with a newborn child who has postpartum OCD, the last thing she's ever going to do is talk about her fears about what if she hurts her child, right? And that's like the last thing she feels comfortable talking about in a healthcare setting even. And so what we've really tried to do is we've tried to identify those patients. Again, 96% of people who have OCD don't service in claims that don't surface to the healthcare system as having OCD, so we can properly route them to the right care at the right time, the right place, the right provider, and they don't have to then suffer in the system. I think it takes 14 to 17 years on average for people with OCD to get access to their right care. And that's a stat that we really want to change. And there are many great groups who are now beginning to focus on that problem with us. But you're spot on. I mean, to get a person who has OCD to the right provider, where it's the right match, where they even realize, they need the right provider. I mean, today it's a challenging effort, but we believe that with community online in particular, you can help people feel the trust needed to actually take their first steps into treatment. And they can also in that same community recognize that there are other people out there going through the same thing as them, and that there's evidence-based treatment that got them better, right? So we have a community-based model that really focuses on that front-end fix. But I think it's a great point you bring up.
Very well said. Well, we have a few questions from the audience that I want to get to. The first is, what is the genetic relationship for patients with OCD? For example, if a parent has OCD, what is the likelihood the child will have OCD? If there is a relationship, is there a better way to leverage parental diagnostics in diagnosis and screening? Anyone have an answer to that?
Well, I think we know that mental health diagnoses and mental health disorders do run genetically, as well as, in relation to what happens to us all as we go through our environment growing up, et cetera, right? So twin studies have shown some of that assessment, as well as if the parents have the disorder, more likely to have children with that disorder. We've done some studies at Evernorth that show also if a child gets diagnosed first, it's more likely that the parents ultimately have a diagnosis as well. So it's sort of that combination of genetics plus environment, but we absolutely want to be sure that we're taking care of the entire the family set as well. So one of the things as a health plan we do as we identify somebody raises their hand for care is we ask a lot of questions about the rest of the family, what else is going on at home, what other siblings maybe should be screened as well as what's going on with the parents.
No, I would agree with that. I think, and that's true not just with OCD, but many behavioral health conditions, that if you've got a family member in there, you want to make sure that, especially if parents are aware that their kids may be at risk, and to introduce that conversation on early. It's actually an act of kindness. It doesn't help to worry about that in silence.
Another question we have here, what supports can be provided to parents or family members to support individuals who have a diagnosis of OCD to help them support the treatment plan?
Yeah, off the top of my head, just from lived experience, I can tell you there's a really fine line between helping your child but also potentially participating in a compulsive behavior. So we often hear that too from parents who have children with OCD. But for what parents can do is they can help somebody adhere to their ERP treatment. They can help ensure that they're actually following through with their ERP homework provided by their therapist. They can also ensure that they help the member or help the patient, do response prevention effectively. So the treatment ERP is essentially where when someone learns how to not do their compulsive behavior when they have their obsessional fear. And so if a parent or a loved one helps support in the process of, okay, look, you're just, maybe you could have this fear come true, just accept the uncertainty, move on. Like that's an example of a response prevention message. If they can participate in that treatment in that way, it can be really beneficial as opposed to reassuring the person or helping with their safety-seeking compulsive behaviors. In addition, I think that there's, for resources, there are educational sessions that family members can attend. I know we do them at NOCD, others do them as well. And you can learn exactly how to support your loved one in treatment. And at times too, just treatment can be difficult, so making sure that you're there for them as they persevere on, and you're supportive and helping them know it's a marathon, it's not a sprint. There's going to be ups and downs. I think that can just be incredibly impactful at times. Like I know for me, at least, just knowing that I had my family there to support me through treatment was huge. Even though they didn't have to say things all the time, I just knew they were there, and that was really impactful. I'm curious if anyone has anything else to add.
I would just add that as a health plan, we spend a lot of time, our case managers spend a lot of time, not just helping families or individuals get connected over to NOCD for direct care, but spend a lot of time educating parents what to expect in care, what's going to happen, what questions should they talk to the therapist about when they're there, and then are available for ongoing questions that come up as well to help make sure that the parents do stay engaged, that they do understand what's going to happen, what treatment means, the length of time this is going to take, and what to watch for from an exacerbation perspective or those sorts of things to make sure they communicate all that information to the treating clinician, things like that.
And I would add to, yes, the health plans, we have resources and it's important. We want to make sure that people are getting access to those. But also just a reminder, especially the family members, progress is not going to be linear, and that's okay. And not to have the family react with massive anxiety if somebody is having a bad day or a bad few days in a row with their OCD symptoms. That's just part of the pathway of recovery. And again, just to be supportive and encourage them to re-engage in their ERP protocols. But you definitely want the families to lend a helping hand.
Stephen, we have two questions specifically for you, so I'll ask them at the same time. The first is NOCD considering doing virtual IOP level of care? And then the second, can you describe the onboarding and diagnosis experience for NOCD?
Sure. So to answer the first question, yes. So we're considering it right now. We have many members who we end up referring out to higher forms of care, and at that point of time, we oftentimes don't see what happens, right? Even though we will try to care coordinate and do our best, at times it becomes sadly a black box. Like we really want to make sure that we can have bidirectional communication, and when you have 50 states you're managing and many different preferred provider partners, at times it can be challenging. So we're considering that in certain states. In other states, we're looking to continuously partner. And to answer the second question, so I'm just sorry, just repeat it if you don't mind.
Can you describe the onboard and diagnosis experience for NOCD?
Sure. So we have a process where we first and foremost help people realize they're not alone in our community. And that's usually the first step somebody takes. And then what they elect to do is they elect to book a 15-minute phone call with a member advocate on our team. And then in that phone call, they can learn about not only OCD, but what treatments looks like. And then if there are evidence-based options near them or available for them in the NOCD network. And so on average, about 80% of our members get in within 7 days. And so we've really focused on that metric, knowing that in the past, that number was 7 months to 2 years if you needed a specialist for OCD. So we've really focused on changing that one stat. And then once they have an intake call and they match with their NOCD therapist, they book their first session on that call. And between that point in time, they'll fill out some forms. They'll actually be able to message with not just their therapist, but also one of their member advocates. So someone like them who welcomes them to make sure that they're doing okay as they prepare for treatment. And then what they'll do is they'll start the diagnostic assessment process. And so it typically lasts across 2 different sessions. And we book those sessions together so people can kind of understand what they're going to go through. And then they go through the assessment process and they learn about their symptoms. So some people have OCD, other people don't. And when they don't, we refer out to an in-network preferred provider partner. That's the typical workflow. I will say this, that most of our members come in through self-referral. And the reason why is, again, this is a very stigmatized issue. People don't want to talk about their core symptoms unless they know they're going to be understood. And when you're talking about OCD manifests and attacks what you love most, and so oftentimes it can be really challenging. The topics can be very shame-provoking, and so our assessment process keeps that in mind throughout every step in the journey, and that journey is connected together with our back-end system, right? We can help every person along that workflow, deliver a real personalized experience to the member, and yeah, that's our process today.
Well, we have a couple of minutes left, so maybe just quick rapid fire. What last message would you like to leave to the audience on expanding access to OCD care? Doug, starting with you.
Yeah, I think the takeaway messages are, as a health plan, we look for partners that are providing high-quality, evidence-based, specialty kinds of care, and really looking for those partners that can do that, collect the outcome data, want to share that back and forth with payers. That allows us then to really make sure we're providing access and referral patterns to get the right patients to the right providers for what they need. And as it comes to, from an obsessive-compulsive disorder perspective, we've really been able to work those pathways out with NOCD, and it's working really well.
And to add, in behavioral health care, there are, I would consider, many different complex segments. One of the interesting parts about OCD is that it's actually very treatable. People can get better, and you can make a significant impact in someone's life. So at scale, if you think about it, it's actually one of the most tangible opportunities to make a major impact today in behavioral health care. We just have to do a really strong job at identifying people up front, and if we can do that, brick by brick, we can build a better mental health care system. And I think this is one of the best places to start if you're looking for a place to start, just because, again, it's severe, it's costly, but people can get better if they get to the right specialized treatment. And we're hoping that the right specialized treatment can be available for everybody, no matter where you live, no matter how much money you make, right? And so we really take pride in that mission at our company because many people have lived that experience. And so I wanted to share that if you're going to look for a place to start, this could be a great place to start.
I'll add on, just from data sharing and transparency and managing clinical quality and being focused on that, not just saying it, but doing. And that's really been a difference in this partnership, that there's transparency in data sharing. And that's how we get better. And that's how our communities get better. That's how our providers are able to improve their clinical quality. And actually, patients are getting better.
Yeah, I definitely agree on the data sharing and in collaboration. Being able to show that people do get better. The one thing I will mention on this too that hasn't really come up is it's really important for people to remember that what was just talked about is a psychotherapeutic evidence-based treatment for a complex condition that people might call it a brain disease, but we didn't even talk about medication, and that's because for most people with OCD, the primary treatment is a psychotherapy. And psychiatry especially, we just get enamored with pharma and the newest molecule that we can prescribe for no matter what the price is. One of the things that I just think is incredible about NOCD is, people will be on medication, and some absolutely need to be, but that's not the primary intervention. And I think it's actually a very good learning point for especially the psychiatrists in the crowd, myself included, who just get so interested in the pharmacology that we forget about sometimes that's actually not the most important part of treatment.
Yeah, absolutely. Well, unfortunately, that's all the time we have. We're a little bit over time, but thank you all so much for joining, and thank you to our wonderful panelists here.
Thank you.
Thank you.